So the next one we are looking at ventricular hypertrophies. Remember, we have RVH and the LVH. So we are starting with right ventricular hypertrophy. So what is right ventricular hypertrophy? Increase in thickness. So these are very important. You see, the artery enlargements are important, but these ones are so important. Here we have increased thickness of RV free wall. As a free wall, like how I drew it this side. This is a free wall. Increased thickness of RV free wall. So that is ventricular hypertrophy. Or increase in cavity size. So what do we expect? What do we expect? I'm using this ECG now. I'm not going to go back the other side. This ECG is going to show us what we expect when there is no hypertrophy. And this is what we said when we were doing normal ECG waveforms. We said the first part for septal depolarization, this is a normal waveform. In V1, we're supposed to have in V1, V2, V3, V4, V5, V6. We said in normal ECG, we should have increase in R wave. This is R, this is S. R, S, R, S. So we should have an increase in R wave as you move from V1 to V6, and a decrease in S wave as you move from V1 to V6. And that one we called it R wave progression. R wave progression. And we said this one represents septal depolarization. We said the normal heart, the left ventricle is thicker than the right ventricle. So the net depolarization vector is towards the left. So we said also ventricular depolarization happens in three parts. First, septal depolarization, and now next one, depolarization of the free wall, and then the third one, depolarization of the basal parts of the ventricular free walls. The first part is going to be septal depolarization, and then the second part, free walls. The left side is thicker than the right side. The net will be going to the left. Remember the arrangement of chest leads. From the right to the left. This one is to the right, and then to the left as you go up to V6. This side. So anything moving away from the positive electrode of the lead is going to show negative. Depolarization moving away from positive electrode of a certain lead will be negative. So septal depolarization is from left to right. That is towards a positive electrode, so R wave is formed. Septal depolarization occurs from left to right, from the negative positive terminal of V6, so it is appearing as a Q wave in V6. So this is septal depolarization Q in V6, septal depolarization R in V1. Clear? Next, the depolarization net will be moving from V1, positive electrode of V1, to the positive electrode of V6. From right to left. It will be from right to left. So it will be shown as a negative wave, that is S in V1, and it will be shown as a positive S in a positive R in V6. So free wall depolarization. This is a normal depolarization, no enlargement, nothing. And then we have a small s in V6, which shows depolarization of the basal parts. So this is what we expect in the normal ECG. What happens if right ventricle is hypertrophied, is thickened. We expect the voltage, if here it was making 2 small boxes, see, 2 small boxes, 3, 4 small boxes here it is making, that is 4 millimeters. If it hypertrophies, instead of making 4, it can make 10. So in hypertrophy, in a normal RV, R wave, receptor R wave, it may be taller. It may be taller. In a normal, like for example in this case, this R is 4 millimeters. If there was RVH, this R wouldn't be 4 millimeters. It can be 10 millimeters in RVH. So in RVH, can remove this one. In RVH, the normal, this one, this small r here, it will disappear. So in RVH, if this is normal, then RVH again, or if it has come, it will be P. This is in V1. RVH. This is R. This is S. Or it can it can manifest as Q, Q, R. But this R is taller than N. So RVH criteria. RVH criteria. Which criteria do we use to diagnose RVH? R wave, initial R wave, this one, to be taller than 7 millimeters, taller or equal to 7 millimeters, RVH. Now because in RVH the right ventricle may be thicker than the left ventricle, the right ventricular free wall may be thicker than the left ventricular free wall, the axis may change. We talked about the axis also. You have to go back in that video and watch a cardiac axis. The axis normally it is towards the left because the left side is thicker. Now if the right side is thicker, remember this is the electric axis, it may alter the electric axis, and where is the RV located towards the right side, so it will cause right axis deviation. So initial R wave to have more than 7 millimeters in amplitude, right axis deviation, incomplete or complete right bundle branch block. It can be there. And then T wave inversions in V1 to V2, for example. In V1 to V2, that one is called RVH strain pattern. RV strain pattern, like that, RV strain pattern. So these things must be there. Or this R wave, this is not the initial R wave, then the R wave after the small q. This is a pathologic Q wave. Not infarction, but because of hypertrophy, it alters septal depolarization and it goes the other side. So these are the criteria for the diagnosis of RVH. RVH diagnostic criteria on ECG. These ones, you need these ones at least. And then other things you can look for is persistent deep S waves in V5 or V6. They remain there, and then since they remain there at all, then it will result into poor RS or R wave progression. These are the criteria for diagnosis of ECG of RVH on ECG, but it is common. It is not common. Causes we have pulmonary stenosis, pulmonary artery hypertension, pulmonary stenosis, pulmonary valve stenosis, pulmonary arterial hypertension, and then pulmonary embolism, and then others, congenital tetralogy of Fallot, etc. This one. Others are going to be secondary causes. And then arrhythmogenic right ventricular dysplasias. Yes, arrhythmogenic right ventricular dysplasia. But yeah, it is this common, but if you find it, yeah, it is worth noting because it can alter the management of the patient. The next thing is going to be LVH. Like RVH, LVH is just an increase in thickness or cavity size of the left ventricle. Again, which leads are we checking? We are checking, this one is a very, very big, important and very common. It is very common. Very common. Why? Because the most common cause is hypertension, and most patients are hypertensive. And the other cause is AS, and it's common. AS is common. AR is common. So you have to be careful with this one. So with LVH, what do you expect? Again, we are checking in all the leads. Check all the leads for LVH. But this is what we expect in 1, if normal, V1 and V6. This is what we expect. This is V6, a very small S wave. Small r, very big R. We expect this one. So this one is, because it has mascaraders. It has mascaraders. So with LVH, instead, this one being, see, in LVH, because this one is showing, this S is showing the normal depolarization towards the left. So it's going to be very tall because the left ventricle is excessively thick. It has to be thicker than RV, but now it is going to be excessively thick. So it will be, this S will be very, very deep. It will be very deep S, maybe from here up to here. And if you go this side of R, this R will also be very, very tall because we finished this concept. The thicker the myocardium, the higher the voltage is creates. So we expect voltage overshoots here in LVH. So without wasting time, we are going to diagnostic criteria. Criteria for diagnosing LVH. Which criteria do we use to diagnose? Now there are many criteria, but the most common, which is even written on this, on the ECG, like for example ours, you see this, it's writing here R in V5 or V6, and then S wave in V1 or V2, in V1. It is 1.22 or 0.78 millivolts. It is Salk and Leon 2 millivolts. So this is the most common. It is called one criteria. It is Sokolov and Leon. It's called Leon, or there were two criteria. What does it say? You take S wave in V1, you add R wave in V5 or V6, and it shouldn't exceed 35 millivolts. It shouldn't exceed 35 millivolts if you add these ones. If it exceeds, it is LVH. Second one, this is the most common. Criteria 2, you add S wave in V3 plus S wave in V3 plus R wave in which read R wave in AVL. So it shouldn't exceed, this is divided into two. For men, it shouldn't exceed more than 28 millimeters, and then for women more than 20 millimeters. The third one, these are many. R wave in AVL, which is exceeding 11 millimeters. It is LVH. The fourth one, R wave or S wave in AVF shouldn't exceed, or which exceeds 20 millimeters. These are criteria for LVH. Now other supportive ones. C5, others. Since this is towards the left, so you can have left axis deviation. And another one can have complete or incomplete left bundle branch block, and then ST changes. What are those changes? T inversions and the ST segment depressions in which reads V3 to V6. So these ones are called LV strain pattern. So how many? 6, 7. No. 6, 7. 7 diagnostic criteria for LVH. You see? So just looking at the ECG very fast, you see that this is LVH. And then if you want to confirm, you count these ones. So causes, we already finished. We said it is systemic hypertension, aortic stenosis, aortic regurgitation, and then hypertrophic cardiomyopathy, then H na dilated cardiomyopathy, and etc. What is more obvious? What is more obvious to find on the ECG is going to be concentric LVH. Concentric hypertrophies are easily diagnosed on the ECG compared with eccentric. Eccentric may manifest as other ECG features, PVCs, frequent PVCs, or bigeminis, polar wave progression. Another one is going to be maybe non-specific interventory conduction delay, bundle branch blocks, but changes in voltages not seen. Another thing, ECG is not sensitive to detect hypertrophies. Otherwise, we may have a completely normal ECG, for example this one, but when the patient is having actual hypertrophies. Here, when you look at this ECG, nothing like any hypertrophy is there. There's nothing like hypertrophy. But you may find this patient had hypertrophy, like LVH. But because the patient was either fat, obese, hypothyroidism, pericardial effusion or pleural effusion, all those ones can mask the effects of hypertrophies on the ECG. So now next part, we are seeing the real ECG and how to interpret them.